The HiGAMS Alliance presents its services for the design, development and use of high-complexity mathematical models for health management. Hypothalamus Artificial Intelligence and GAMS have entered a technology alliance to jointly provide services based on advanced mathematical models. Their technological capabilities, in artificial intelligence and mathematical programming, make them the ideal partners to face the challenges that exist in advanced analytics applied to health sector. Due to the experience of the companies, this alliance is particularly strong in optimizing the management of healthcare companies and organizations. The set of services and products offered can be used to support research and technological development in this area of knowledge. Operations research, or, is a distinctive instrument that generates the greatest benefit for the end users of the health system at the lowest cost. Its value has been well recognized both globally and nationally. Collaboration between public health experts and AI developers is essential to align mathematical applications with public health priorities, offering a range of potential cost savings and economic benefits that go far beyond immediate implementation. Cost savings optimize resource allocation, improve disease surveillance, and streamline healthcare processes. Economic benefits include improved health outcomes, reduced healthcare burden, increased productivity, and increased innovation. Some examples are optimized resource allocation, improved disease surveillance, optimization of healthcare processes, preventive interventions and early detection, optimization of the healthcare system, reduction of the health burden, improved decision-making and resource management, accelerate drug research and development, savings in medication management, socioeconomic, and technological advancement and innovation. Artificial intelligence, precision medicine. Every year, 550,000 people worldwide are diagnosed with head and neck cancer. This incidence is increasing, more than doubling in certain subgroups over the past 30 years. Most patients will be treated with radiation therapy, which focuses on the tumor mass, and in areas at high risk of microscopic tumor spread. Strategies are needed to mitigate the adverse effects of incidental irradiation on organs at risk. What could artificial intelligence improve? There are many aspects in the fight against cancer that artificial intelligence could improve. Some are: segmentation is time-consuming, an expert can spend 4 hours or more on a single case, and duration of resulting delays in initiating treatment is associated with an increased risk of local recurrence and overall mortality. And when it must consider the socioeconomic impact, derived from the pandemic and its control. Simple but wrong, it is not an option, because the equivocation during the management of the pandemic is an error that can become a horror. Complex but right within the complex there are more options, suddenly the road can be narrow and long, but safe. The presentation consists of 5 videos, and their supporting documents, which summarize all the applied research work carried out by HI, to contribute its knowledge in highly complex mathematical modeling, to the optimized management of pandemics such as COVID-19. These are: pandemic management using advanced artificial intelligence, epidemic simulation model, general epidemic optimization model, epidemic economic impact model, and Kalman filter estimation model of the epidemic state. Mistakes in the management of COVID-19. The Lancet, the most important report on the management of the pandemic, denounces a global failure in the face of the COVID-19 health emergency. It said, government's massive mistakes in managing COVID led to 17.7 million preventable deaths. As Albert Einstein put it, to raise new questions, new possibilities, to regard old problems from a new angle, requires creative imagination and marks real advance in science. Distributing scarce drugs. Case California State. In California, the Drug Distribution Project, DDP, was created in the fall of 1999 to implement the drug distribution portion of the Pharmaceutical Release and Settlement Framework Agreement. The settlement required 19 pharmaceutical companies to provide $150 million worth of drugs for free to 200 California clinics and hospitals over 3 years. The Institute of Public Health was responsible for distributing these medicines in a fair and equitable manner. In 2001, 6 additional companies and $20 million were added to the project. The DDP decision support system used operational research concepts to distribute drugs in a timely and fair manner, considering various clinical, pharmaceutical, and allocation constraints. Many uninsured patients who would have otherwise struggled or not had access to medications have received their prescriptions and maintained their health. Although an accurate count is not available, it is estimated that between April 2000 and February 2003, 2.6 million prescriptions were filled every 30 days as part of the DDP. In addition, many pharmaceutical companies are exploring the use of DDP's DSS to improve the operation of their charitable drug programs. In 2000, the MedPin drug distribution system came into force. Provided 3 years of direct benefits of approximately $57 million in medication annually to California's indigent patients. Although the overall training and education benefits of the MedPin program continue at some level, the end of direct drug benefits came at a difficult time. California was facing a severe state budget crisis that was already putting unprecedented pressure on outpatient clinics and the state's ambulatory safety net due to reduced reimbursements and an increase in the number of uninsured outpatient clinics in this state's safety net, while MedPin drugs were no longer available to assist them. DEA, Data and Development Analysis. Evaluating hospital performance. One of the problems of business administration is the comparison of facilities, for example hospitals, that are not homogeneous, in inputs, consumption of resources, and outputs, products, benefits and costs. Effectiveness, efficiency and productivity. Effectiveness: the extent to which service providers' performance meets customer objectives. Efficiency: how successfully an organization uses its resources to produce products, and the degree to which the observed use of resources to produce products of given quality coincides with the optimal use of resources to produce products of a given quality. Productivity: the relationship between outputs and inputs. A firm is technically efficient if it obtains a certain level of output with the minimum combination of inputs. Allocative efficiency is obtained when the company, in addition to being technically efficient, carries out its production process with an adequate combination of inputs considering the costs/prices of inputs and outputs, respectively. Efficiency is a relative concept such that the result of an economic unit must be compared with a standard. In this sense, the measurement of efficiency requires 2 stages. Efficiency is a relative concept such that the result of an economic unit must be compared with a standard. In this sense, the measurement of efficiency requires 2 stages. The first step is to determine a standard reference function that indicates, given a fixed production technology, the maximum level of output that can be obtained from different combinations of inputs. The reference function or frontier function can be either a production function or a cost function, or even a profit function. The second stage consists of comparing the results obtained by each unit of production with the standard frontier, so that the existing deviations will be characterized as inefficient behaviors. Non-parametric efficiency analysis, better known as DEA, Data and Development Analysis. It was developed by Charnes, Cooper and Rhodes in 1978, and has been used to estimate the efficiency of DMUs in various fields of application. DEA is an efficiency measurement model, supported by linear programming techniques, which aims to evaluate the relative efficiency of different homogeneous DMUs. The application of a specific model for each DMU evaluated allows obtaining an efficiency measure for each of them. DEA is an extension of traditional relationship analysis for the case of multiple inputs and outputs, is that, to analyze the efficiency of a particular DMU, it is considered efficient if no other DMU is capable of to produce a higher level of outputs using the same inputs, or if to produce the same level of production from a lower level of inputs. Thus, it will be possible to distinguish those units that behave efficiently from those that are not, so that efficient units define the efficient frontier. The figure shows an efficient border, built on the basis of 6 hospitals, in which the hospitals located in the cities of Manchester and Glasgow define the efficient border, and the others present a certain degree of inefficiency, which increases as they move away from the border. DEA allows the calculation of technical efficiency indices by solving multiple linear programming models based on the data that represent the set of DMUs to be evaluated. The objective is to obtain a scalar that represents the minimum proportion to which the consumption of inputs can be reduced without reducing the amount of product produced. The greatest advantage of the DEA is its flexibility, in the sense that it imposes less restrictive conditions on the reference technology and in that it adapts to multi-product contexts with relative simplicity. DEA is useful in many areas, such as the efficiency comparison of equipment, offices, branches, people, machines, and others. What questions can DEA help us answer? How do I select appropriate role models to serve as potential benchmarks for a performance improvement program? Which production facilities are the most efficient in my organization? If all my operations were performed according to best practices, how many more service disruptions could I produce and how much could I reduce my resource inputs, and in what areas? What are the characteristics of efficient operating facilities and how can they guide me in choosing locations for expansion? What is the optimal scale for my operations and how much would I save if all my facilities were optimally sized? How can I consider differences in external circumstances when evaluating the performance of individual operating facilities? Optimize the capacity to respond to health demand, or solution to a health crisis. This situation is related to the accumulation of patients in a hospital, or in a group of hospitals, due to a structural problem, greater demand for hospital services that can be attended, or circumstantial, due to an event that unexpectedly generates a peak in demand that exceeds the capacity of the system. The first situation can only be solved with the expansion of the system, and the second through the optimal management of clinical resources that recovers the supply-demand balance in the shortest possible time. After a short-term health crisis, a process of recovery of normality and health activities will be necessary to absorb the excess demand that has accumulated during this period. Normalization is achieved through the necessary actions, which push the capacity to its maximum limit to absorb excess tails. The recovery of the ability to attend the health demand is a process slowed down by the management of the risk of contamination of patients in the hospital. This is a highly complex scenario that can only be addressed through a decision support system based on mathematical models. There is no other solution. Modeling the clinical system. The mathematical modeling is organized around the patient's care process, the only way to achieve the adjustment of the capacity to resolve the care pressure, given the chain effect of the concatenated waiting queues, typical of health care. The only way to get out of the health quagmire, and maintain excellence in care, is to do to patients what needs to be done, only what needs to be done to them, at the right time, in the best possible way, and controlling the risk of contamination. This acceleration means shifting more demand to the next link in the chain. This coordination requires the flow of the process of all the diseases treated in the clinic, using all the resources, and if necessary, acquiring, or renting, equipment to improve the process. Detailed process modeling is necessary to be able to build mathematical models that allow us to solve the problem in a comprehensive way. For example, in a modeled process of a hypothetical traumatology service, 13 linked waiting points are produced, which will be managed jointly and according to the uniqueness of each of them. The result is the optimization of the scheduling of hospital services, for all patients and the resources used by the hospital, for each period of the planning horizon. Health network design. Like any public service network, its design is essential for connectivity of the facilities in order to guarantee the feasibility and quality of the services offered, all at the lowest social cost. This must be done with mathematical models specialized in the subject, including the financial risk of the decisions made. A network is used to represent the model. The nodes correspond to candidate locations for lower-level healthcare facilities, LLHCs, and higher-level healthcare facilities, HNHCCs, and require concentrations, or both, because population centers are feasible locations for both health facilities and patients. This is a nested hierarchy of two-level flows. Each LLHCC must be located within the service coverage radius of an HLHCC, and the demand points must be within the coverage radius of at least one LLHCC or HLHCC. LLHCCs are also related to improving demand responsiveness. If the demand points are within the LLHCC or HLHCC coverage radius, the services are transferred. The model reduces patient and service transfer costs by locating HLHCCs and LLHCCs based on demand points and their magnitude. In 2023, in Iran, a two-stage optimization strategy was used to solve the problem. In the first stage, the facilities are located to maximize the demand covered, and in the second, patients are assigned to facilities located according to their coverage radius for several periods. The problem belongs to the NP hard class and is solved using a linear mixed integer programming (MILP) model. In 2005, Hy implemented a model for the location of health facilities in the city of Medellin. Enterprise risk management for healthcare organizations. This is the essence of supporting the health sector, as the sustainability of the sector depends on it. Like Herbert Simon, Hypothalamus AI believes that the computer-based mathematical modeling is the greatest invention of all times. Thank you for your attention.